Thank you very much for having me. So my name is Sandro Di Simplicio. I'm one of the vitreoretinal surgeon, cataract, refractive, and something else in Newcastle. So thanks for having me. It's very nice to be part of this panel. I'm gonna have a little scroll through what the geographic atrophy sort of is, and more than anything, what are the treatment? What was the treatment in the past? What is likely to be, or what it looks like it might be the treatment in the future, and definitely the most important thing, what's the treatment in the present, because we do have patients ask us questions and we need to give them answers about what we can possibly do. So about geographic atrophy, there isn't really very much to invent. It's an advanced form of age-related macular degeneration characterized by atrophic lesions. At the moment, it's estimated about 200 million people worldwide have AMD. This is going to grow to about 300 in 2040, and by 2050, in the region of 5 to 5.5 million people in the world will be affected by geographic atrophy. So it's definitely by no scale a small problem. The background at the moment, as we said, in the United States, about 1 million people are estimated to have geographic atrophy in years which go from 50 to 80. Age is very important because there is a prevalence and there is an increase in frequency in geographic atrophy, which becomes 4 times more likely for every 10 years of your life. So for 0.15 when you are about 50, 60, to almost 3% when you are approaching 80. And our aging people, our population is aging, so it's not getting any younger. So it's more and more likely that you will come across this pathology more often than not. So what was the treatment of the past? That was the treatment of the past. There was no treatment in the past. So the best that you can tell your patient was really to get hold of a nice Labrador to walk them around. And that wasn't really good enough. What's likely to be the treatment of the future? Now, this is going to be a 3 hours lecture probably per se, so we have 8 minutes left, so we're going to keep it a little shorter than that. There are some genetic studies, some drugs which are being developed at the moment. You may have heard about the Novartis GT005. That was a promising trial, so promising that it has been dropped in September 2023 due to safety concern. The other one is the one that you see on the screen now. It's still ongoing, was called Hamira, now it's called Janssen, is a phase 2 study which seems promising. What does promising mean? Promising mean that I am 47 at the moment and I don't think I will see this treatment in the real world by the time I retire, all right? These are treatments which takes ages to develop, and you can't really hold your breath for this to become a reality. There are other possibilities still in the future, which are RPE replacement. They can be done by cellular suspension, patch transplantation. You can see everything on the screen. It's pointless for me to go through everything. It's just a waste of time. You can do it yourself. All of them have their own advantages and disadvantages. Some are a little bit more promising than others. Some are a little bit more sort of likely to become a reality sooner than the other one, but still, it's not something which is really likely to happen particularly soon. What's up today? Today, there are 2 medical treatments. One is the Syfovre, and the other one is the Izervay. So, I say today, but are they really? Because unless you are American and you live in the United States, you can't get hold of this. So it's today, but so to speak. On top of that, look at the date of this report. It's dated the 14th of December 2023. It's 2 days ago. And Apellis, the company itself, says that their drug is unlikely to be accepted in Europe. This is due to the benefits, which probably are not as good as they should be. So, is this really a today treatment? It's not, and probably will never be, in Europe at least. The other drug is under examination at the moment with the European Agency of Drugs, and hopefully it will become available at a certain time. So, what is our option? Well, our option at the moment is this one here. This is the only option which is available. It's a surgical option. It's something which has one little complex passage in it, and all the rest is pretty much plain sailing. And I'm explaining myself. The treatment is limited to patients who are phakic. So there is a shift in paradigm here. Every time now you see patients with geographic atrophy, to try to give them a little bit of better vision, one of the things that you suggest is for them to undergo cataract surgery. I am no one to tell you to change your practice, but what I would go as far as suggesting you is if you see a patient with geographic atrophy, if you see a patient who you think may benefit from this treatment either now or in a few years' time, stop and think before getting him through the cataract surgery. Because if you do, you are taking away the only actual chance that they have in this moment in time to gain a little bit of treatment. That's the downside of this device. All the other ones, as we said, are really advantages. First of all, it's a simple procedure. It's a cataract, so whoever can do a cataract can do this procedure here. It's a one-off, so you implant it once and you can forget about it. I mean, you'll need follow-ups, but you know what I mean. It's not like a monthly involvement for the patient. And more than anything, is real. Is something that you can have, is something that you can implant, is something that you can discuss with your patients about, is a real option that today in Greece, here in Athens, or by all means in all Europe, is available to all of us. Is it safe? Does it work? Yes, it does work. They have implanted in the region of 300 of them in worldwide. This is a study from my friend Mario Toro in Italy, where 100% of the patients gained one line. That's fair enough, but what's quite impressive is that almost 60% of them gained 3 lines and 25% of them gains 4 lines. Another study still on the same line from Savastano, Rizzo, and Caporossi show exactly the same on their cohort of patients, where distance vision and near vision all improved and maintained at 1 month and 3 months with no statistically significant endothelial cell loss. But who am I to tell you this? I mean, I'm just a surgeon. I've done only a handful of cases. You don't really have to look at me and believe at what I tell you. You should believe them more than anything else. If you can read this letter up here. Yeah, and if you can read this letter here.
For Paul Dobson, life is looking a little brighter.
Very good.
In March, he became the first patient in the UK to receive a pioneering implant to improve his vision.
I've been his figure and I haven't got a blind spot. We are sort of taking somebody who's half blind who'll be able to see again.
You must feel very fortunate.
Very, very
For
fortunate.
another pioneering implant patient, the challenges of getting used to the new lens are far outweighed by the benefits. Just months ago, Janice Morris from South Shields was unable to recognise friends and family.
To be honest with you, I've got my life back. I'm doing really pretty much what I want. Like in the house, I can make my own coffee, you know, where before the sugar was over the floor. I thought I was never going to be able to see anybody again. That was how bad I was. A million factors are not even forward back being given back.
So these are 2 of my patients. So really the take-home message is a message of hope, right? It's a hope for you as a surgeon, because at last you have something that you can discuss with your patient, an option for them to look forward to. It's a message of hope for your patients, because they don't have to give up. they can really believe that there is something that can be done for them. And really, it's a message to say that it's not over. You do have a very important problem which has taken away a lot of your vision and it has impaired your life a lot, but now you do have an option. The referral pathway has been discussed before, so I'm not going to go through that again. And with that, I thank you for your kind attention.